Thank you for joining us for our educational webinar, Managing Your Low Back Pain. Tonight's speaker is Dr. Ying Chen, neurosurgeon at OrthoNeuro. Dr. Chen is a board-certified neurological surgeon with spinal interest or special interest in spinal disorders with an emphasis on complex spine and micro-neurosurgical procedures of the spine. In addition, he has a special interest in minimally invasive techniques in spinal surgery, including endoscopic procedures as well as neuronavigation technology. Dr. Chen will answer questions following his presentations. Please type your questions into the Q&A below at the bottom of your screen. Dr. Chen?
Hi, good evening. Thanks for inviting me. Hopefully everybody can hear okay. I think Hannah is kind of be our moderator, and I think there's a chat option there that you can submit your questions. And then I'll go through my presentation, and then at the end we can answer your questions. So can everybody see the slides? Okay, I don't hear any complaints, so we'll start, and then I'll give you a short, brief presentation on low back pain. So again, I'm a neurosurgeon by trade, and I specialize in spine surgery. I don't do much brain anymore, so this is my specialty. And we're OrthoNeuro, we're in a private practice, so I see mostly degenerative conditions and of the spine, and do the surgical aspect. But we also have non-surgical doctors in our group, and that can help us in terms of sorting out, what the patient needs. So this is our New Albany office. If you haven't been to, we have multiple offices around the Central Ohio area. And I welcome you to look into that on our website, learn more about that. So again, like Hannah says, my interest is more in the minimal-invasive procedures, and we do also offer quite a bit of more contemporary treatments for spinal disorders, and so I'll kind of be talking about some of that towards the end. But certainly this is not all just a surgical talk, so I think hopefully that'll be helpful in terms of giving you some information on the contemporary thoughts on these low back conditions. So I don't know if you're familiar with this. Our government actually published the statistics on we call it the burden of disease and injuries and risk factors. So and they have data on the country as a whole, and then the publication that also divided into different states, and then have data on that, and it published on a regular basis. The slides is a little bit old, but still relatively relevant. So basically, you're looking at the conditions that causes disabilities in our country, and rankings. So when we talk about DALY, D-A-L-Y, if you see that on the screen, that's disability adjusted life years. And so if you compare, this is the 2016 in the middle column here, and compared to the 1990s. And as you would expect, the top few conditions, the ischemic heart disease, lung disease, diabetes, that's always usually on the top of the list. But if you see that the low back pain is also way up on the list in terms of causing disabilities in our country. And it's certainly universal in the developed countries, as you'll see. Certainly we're not in the developed countries, we're not looking at more the communicable diseases. We have more handle on that, but a lot of these conditions are more related probably to our lifestyle, and maybe some of that's maybe genetics and how we deal with that. So in terms of chronic low back pain, so we define that as chronic. Basically, you have had low back pain for long periods of time, and the definition greater than 6 months despite conservative treatment. And as you know, I always compare that to a toothache that never goes away, right? And how distressing that will be, and causes us, become less productive and with the disability. So again, so low back pain is it's a fairly significant cause of productivity loss and disabilities in our culture. So if we look at again, so I emphasize that the condition is different from country to country, culture to culture. So, but in the Western society, developed countries, you see these problems. And so some of it are related to lifestyle and some of the risk factors associated with our society. And you can probably guess too, if you look at the risk factors that contribute to these disabilities, as you can see way up there, tobacco use, high body mass index, obesity, as you know, is fairly relevant in this country, that can contribute to a lot of the disease processes that we talked about, diet and exercise. That applies to different conditions, including low back situation. Yeah. So those are the things that I think that'll help us in terms of sorting things out and how we should tackle this disease conditions. Not everything is surgery, obviously. So that's kind of what I'm trying to get at. There are plenty of data, although it seems intuitive. Overweight and obesity causes low back pain. Both from a biomechanical standpoint in terms of high body mass index, and puts a lot of stress on the structures in the body, joints and ligaments. But there's also data on the biochemical effects and affecting the microorganisms that can be associated with back pain as well. The other thing that are kind of pretty popular in discussion now, and you see that in probably infomercials and literatures, has to do with inflammation. So those things that we're looking at now, that there's significant association with the inflammation with all kinds of arthritic conditions and other conditions such as fibromyalgia, Crohn's disease, inflammatory bowel disease. There's a significant association with some sort of inflammation, and some people tend to prone to be inflamed, to be more inflammatory than others. And so we're starting to look at that also for low back pain with association. And certainly if you can sort out, which patients or which persons that are prone to be prone to inflammations, and they may be more susceptible to these type of degenerative conditions and arthritic conditions. The things you may have here in the news as well. So gluten diet, again, is also associated with sensitivity and chronic refractory low back pain. So there are data out there as well. And so these are modifiable factors, right? So besides genetics, how we're born with some of these lifestyle choices and these type of biomarkers may be something that we can affect, and it maybe can help us in terms of understanding how to go about managing this condition. So if you look at the global, so we talked about the multifactorial problem with low back pain is such a broad condition, disease, and how we deal with that. So some people respond to pain differently than others, right? So some more respond to pain more in a positive way, and some don't. And it's a multiple factors in terms of our genetics, how we're born with, our anatomy, and just how our psychosocial attitudes towards these, and then depends on where we are in our developmental state, right? So younger people versus older people, how we deal with this condition, and then you put that together with all the anatomical changes that's going through as we age with our nervous system, musculoskeletal system, and how we react to that. And there are multiple factors here that that we suggest, and looking into emotional factors, coping responses, how you deal with this from social and physical standpoint, and your lifestyle choices. So it's a fairly broad type of way of looking at low back pain again. So the good news part is I always tell people the majority of people that come in or have low back pain has no clear specific causes, right? So we call these more benign type of pain. So even though it's common, we say, most adults in our lifetime, greater than 90% of us will experience back pain at some point, right? So, but as long as the back pain is manageable and it does not last a long time, becomes chronic, then then that will be in this bucket here. So the ones that are obviously needs immediate attention or reasonable attention are the small groups of people that maybe have serious or systemic pathology, like infections, malignancy, cancer, and then other degenerative problems that causes such as disc disease, stenosis that causes, or instability that causes neurological injury. And so again, these are by far the not as common, but those are the people that will need to be triaged to a surgical specialist probably more quickly. For the most part, so what we need to do is looking at what we can do both from non-pharmacological and then pharmacological and surgical way to manage this situation, because it's such a significant number of people. So you want to do it in a cost-effective way. So so there are some suggestions, and we call these a functional cognitive functional therapy. And so basically looking back and treating all those global factors that we just talked about, and how to go about modify those factors. Yeah. So so again, so kind of so in this proposal, looking at kind of a three-pronged approach. Right, so you have the exercises, therapeutic exercises, looking at yoga, Tai Chi, and you're looking at these different conditions, chronic low back pain, knee osteoarthritis, fibromyalgia, and the family practice group kind of looking at all the data and to see what are the effects. And there are certainly some moderate evidence for therapeutic exercises for low back pain, certain exercise activities, and then you look at the mind-body therapies such as biofeedback, mindfulness exercises, progressive muscle relaxation. You may have heard of some of these things, and then therapies. They tend to be kind of a low evidence value in terms of looking at the improvement, but I think it's a good adjunct. And then complementary modalities, certainly spinal manipulation, chiropractics, massage, and quite interestingly, acupuncture seems to have good data in terms of short-term benefits and pain relief from acupuncture. My mom gets acupuncture. She has a neck degenerative neck problems. She gets acupuncture and she swears by it. So, so those are the approaches before you hopefully kind of tackle this before you start the pharmacological medications and the more aggressive type of treatment, right? Now, from a structural standpoint, we gotta look at the anatomy a little bit. So the spine, a bite of it itself, there's also muscles and ligaments that holds things together. So this is kind of more going from superficial to deep. So it's kind of a side view of the back of the torso. These are the rib cages, and these are the shoulder bones, the scapula. And so the back has layers and layers of muscles and ligaments, right? So the outer layer, you have these big muscles. And then if you peel those off in the deeper layers, you have even more muscles and ligaments that run along the spine. And all these have nerve fibers, these yellow structures that kind of comes out. These are nerve fibers that's supplying these tissues. So these structures can sense pain, right? So and the ligaments provide structure as well as support, and it allows us to move, right, for mobility. And some of these muscles run up and down the spine, so essentially everything is all interconnected. And that's why sometimes we call these refer pains when the pathology, people have maybe a disc problem in the lower back, but they may have pain in their shoulders and in the upper back and the neck, and then vice versa, because everything's all connected, right? So we got to look at that. So a lot of the physiotherapy, spinal manipulations, certainly we're working on these soft tissues, right? And then people that have injections, then you're trying to affect these nerve fibers when they're having pain, and you can provide medications in that area. So, and if you take those muscles, peel those off, and you start to see the bony and the nervous structure. So again, the kind of the side view of the vertebrae here, back, and a kind of a side view here. So just to give you a quick anatomy lesson. So this is the front side here. So these big blocks of bones, those are the vertebrae. So that's a bony part of our spine. And there is in the back here, again, there's a bony part of the spine called the spinous process. And that's where the ligaments and the muscles attaches to, and that allows for mobility and movement. In the front here, this is more support. So this kind of a grayish area, that's the disc. The disc is the cushioning part of our spine, kind of like a shock absorber, right? So, and so the front part here, the vertebrae spine here is for support. And that's where our weight is placed on the vertebrae. Down below here, if you look at it on this side, that's our tailbone, or we call it the sacrum. And in the sacrum, there is a big surface area here that's connected to another bone called the iliac bone. So this is called the sacroiliac joint. And just like any joint, the sacroiliac joint can develop arthritis as well. People and the pain that can create kind of more in the lower back and the buttock area, and people call that as a back pain as well. So people that come in with back pain may not be a spine problem; it's a sacroiliac joint. Now on the back side here, now you can see there is a canal inside the vertebrae here. So the vertebrae, the bony part, is protecting these nerves. And the nerve comes from the brain up top and travel as a spinal cord, kind of pinkish area, that's the spinal cord. And then they spread out into nerves here. So they come out of these holes here, and on the side here is called the foramina. And they go down to our legs and supplies the leg. And so they have these nerve fibers that travels up and down. And if you look at this, we call this cauda equina. Basically, it looks like a horse's tail. So these nerves can be compressed by structures around the area. So when there is the disc bulging or herniated disc here, it can push against that nerve. It can cause a lot of inflammation. People have in the backside here, there's also the vertebrae are connected by joints, and these are called facet joints, and they can develop arthritis and start to impinge upon the nerve as well as chemical inflammation around the area. So that condition is called stenosis. And so these are kind of more of anatomical things and that we see. So by the time people start developing these kind of pressure on the nerve or irritation on the nerve, then they end up come see the specialist. So this is kind of a blow-up view here again of the horse's tail, they call it equina, and the nerve comes out here. So there's a hole here, the foramina, and that can become narrow or called stenosis, and the nerve can be pinched. Or in the front here, the disc where the disc space would be, if there's a bulging or herniated disc that can cause compression on the nerve. So if you look at it microscopically, so this is kind of a slide view, kind of a side, you basically cut the vertebrae in half, and you can look at the structures of the disc itself. So the vertebrae, and then the disc is kind of these white parts. So the normal healthy disc on the left side here. The disc consists of the central core. So the central part of the disc has basically kind of a jelly type consistency, and it has hydration. So it basically hydraulics, it absorbs water content, and that gives you that shock absorbing capability. On the outside of the disc here, around the disc, there's a band of fibrous tissue that's holding the jelly together. So that's called the annulus. And so you can see the layers and layers of the fibrous tissue that's holding things together to keep its stability and give you that shock absorber. As we age and as the disc starts to degenerate, you lose the hydration. And you can actually see that on the MRI. So you don't have as much water content inside the disc space. And so the disc starts to collapse, and see how it's not as tall as the normal disc. And then it can bulge forward, so backwards. So it's starting to bulge as it collapses. Yeah. And then the more degeneration, then the outer membrane, the fibrous membrane starts to tear. So we call these annular tears. So this pink tissue here, that's the tearing there. And so once it tears, all the chemicals can get inside the disc space itself and causes basically a lot of inflammation. And the nerve fibers, the pain nerve fibers can start to grow inside into the disc itself. And kind of like a toothache. Yeah, so the nerve fiber is there, and then sensing that inflammation there, and then so it becomes painful. When you think of like a root canal, right? So the nerve fiber is kind of exposed in there. And then at the end stage of the degeneration, now there's no more disc left. And so the body replaces with basically scar tissues, and then they can develop calcium buildup. And so the calcium starts to grow inside, and so basically loses mobility. And once it's completely collapsed like this, and then you start to develop these bone spurs, so the osteophytes, these pointy things, those are calcium buildup. And once you have these bone spurs, then it can encroach into the canal, right? So the holes and the canals where the nerves are, and can cause a compression of the nerve. So there's a significant structural changes. So once it starts to degenerate like this, unfortunately, there's not as much we can do now at the end stage here, because structurally it's already gone, right? So if you want to try to reverse the process, you want to try to catch it early if we can, and to see if you can reverse and regenerate that disc. Unfortunately, it's very difficult to do that. So from a biomechanical standpoint, the disc itself is a very harsh environment. There's no blood supplied inside the disc space itself. So when you're talking about stem cell therapy, it's very difficult for the stem cells to stay viable in there. But there's some solutions for that. So we'll talk about that in the end. But kind of touch on that because this is, again, another kind of popular topic now. People are looking into stem cell therapy. So we can talk about that in a little bit. So from a surgical perspective, so that's kind of where my specialty is. So you know, you try all the conservative treatment measures, and but then, you know, if you have a structural problem, then we had to deal with that. So I kind of generally break it down into a couple of categories when we're looking at surgery. So when I explain surgery to people, so really the top two, so we call it decompression and stabilization. So kind of break that into two. So that's kind of a broad way of looking at different things. So the decompression surgery usually is more, people think of it as less invasive and typically not as painful. It's an outpatient type procedure. Stabilization involves replacement of parts and or inserting hardware inside, and so it becomes more invasive. But you know, it's kind of blurring. So they're you know, less invasive procedures and non-invasive procedure that we can use to stabilize the spine. So it all depends on what the person needs in terms of what their needs are from a surgical perspective to treat the condition. And the third, obviously our holy grail, will be to regeneration, is to replace. So replacing the parts, if you can regenerate these parts in the spine, that will be the most ideal situation. So from a decompression standpoint, so we talked about generally think of it as less invasive, and there are many ways of doing that. You see that on TV or magazines. You know, people come home with a small Band-Aid, you just do a small incision, and you can go and basically clean out these bone spurs, arthritis, or these disc bulging. You can shave them off. So it's from a mechanical standpoint, because something is irritating the nerve or compressing the nerve, that causes pain, then you can go ahead and remove some of those structures. As long as you don't remove too much of the bone or disc or a structure material, then you hopefully still keep the stability of the spine. Because if you start to remove the joints, remove too much of the disc, there's no support there anymore, then things become unstable. Then you need to something called a stabilization, like we talked about. So some of the things that we can do now is a scope. So people are familiar with a scope in joints in the shoulder and the knee, you know, other joints that orthopedists do. So we have scopes for the spine as well. So you can go in and clean out the disc space, the joint space through a small incision and inserting a scope. And there's a camera that's attached to it, so you can see inside. And there are instruments that you can go in and to remove things. And you use an X-ray to guide our anatomy and to get us to the space that we need to. And so, like a herniated disc, you know, small decompression type things, we can do it through a small incision like this. Yeah. So this is a more contemporary type of treatment. And the stabilization, I don't know, people have seen or heard of spinal fusions. That's where people have screws and pins and rods. Maybe you heard of people that have these type of procedures. So this is kind of a standard traditional way of stabilizing the vertebrae, right? So if we need to say the disc is completely gone, so like in this situation, the L5S1, the disc is already degenerated, there's no more cushion anymore, we need to remove the disc, or if we need to remove bone to decompress the nerves, and you stabilize it with these screws, and then you connect them with the rod to stabilize. So that the downside is obviously you reduce the mobility, right? So this part of the spine kind of move in one unit, so there's no mobility, because the spine is designed for a reason. When you have these vertebrae stacked on top of each other, is to provide mobility as well as support. So the downside with this is you lose mobility. The other thing being that in order to install these screws, you have to strip all the muscles and to get to the vertebrae, and so you can put in these hardware. So the idea is to find less invasive way of performing these type of procedures. And there are different ways we can do these type of procedures through the scope as well for smaller type fusions. Obviously, these long fusions, it's doable, but obviously takes a long time, multiple incisions. But there are some other treatment options now, less invasive. So this is one of the devices that we're using now. So basically, the two vertebrae here in between the spinous process, and you can put in a little kind of a button, if you would, that basically clamps them together. And there is a screw there that's basically going through them and clamps it together and stabilize these two vertebrae together. So in certain situations, if your instability is not severe, this may be an option for people, right? So instead of stripping the muscle, make a big incision, you can go through a small incision and get the stabilization that you need. So this is usually performed in conjunction with some other procedures like decompression or something, but that's available for us. The other thing will be joint replacement. So people heard of total knees, total shoulders, there are joint replacements elsewhere in the body. So in the spine, you can also replace a joint. So there's also artificial disc device that's available. We don't use a disc as much because most people have more than just a disc problem. So if you just have a disc problem, obviously disc replacement is a very good option for people. But most people end up have arthritis in their joints as well. We call that facet joints, like we talked about before. And so I think ultimately, I think for most people, once you develop that degeneration on the right side of that slide that we talked about in the anatomy, then you really had to basically remove the disc and then the joint, and then you had to replace all that. So this device here, basically there's a little plate here, and then there's another plate, and they slide on top of each other, kind of like a ball and socket joint, like so. And that basically serves the purpose of that facet joints. It allows motion, but at the same time, it stabilizes the vertebrae, right? So that's kind of the next best thing in terms of stabilizing. How do we stabilize the vertebrae without having to fuse it together? So this is available now in terms of not available in the US in terms of commercially, but we have access to it. We're doing a clinical trial for the FDA so that we can get this approved in the country. So we have access to that through a research clinical trial. So that's something that if you are interested or maybe a candidate for that, definitely can look into that. And then lastly, in terms of regeneration, that's still pretty early. So I think that's the next step that we need to get into in terms of mechanical replacement. But it would be to regenerate the tissue altogether, right? But it's still very difficult. So multiple ways. So where do you get your stem cells from, right? So if you read the commercials and do the literature research, there are different sources of stem cells. And there are stem cells treatment therapies for other joints. And in the spine, unfortunately, it's like I said, the spine, the disc is a very harsh environment, and it's very difficult to make the stem cells to grow. But a lot of research is looking at, we call them mesenchymal stem cells. So these can be harvested. Primarily, it's more in the bone marrow, but the tissues can be found in the fat cells and then umbilical cord cell. And when you take these cells, the stem cells, basically they're pluripotent, meaning that they can grow into whatever tissue that you want it to grow. Key thing is giving them the right signal. So you say, hey, I want to grow this into a nerve tissue, or I want to grow into a cartilage, I want to grow into a bone, and they can do that. So you basically nurture it in a petri dish, you grow them, and then you get enough of the cell that you want. And then the easiest way will be straightforward way would be, okay, you inject those cells into the disc, and then hopefully those cells turn into a disc, and then basically regenerate that disc, right? So, but it's not that easy. So the disc is hard. Like I said, if you inject there, you need to have a certain amount of cells in there to become viable. But if you do it directly this way, it's very difficult to have the cells survive. So, so other ways is you can put some kind of scaffolding, and then putting in some growth factor, basically some other formula or recipes in there, and then grow the tissue together, the cells tissue together to make it so that it's more ready to grow into whatever the cell you want it to grow, and then you inject it in there. And then you try to also add something in there, maybe some kind of scaffolding to allow it to latch onto it so that it doesn't leak out or go somewhere else. Because a stem cell, if it leaks out and it goes somewhere else, and it becomes some other tissue. So some of the things that you can see is they can develop into bone. And so they become growing bone to kind of go back to what we talked about, the bone spurs. The bone spurs may not be what we want. The other option, though, I think this probably has more promise, would be tissue engineering. So this is basically kind of an artificial disc structure, right? So you can give it basically almost a structure of a disc, and then you grow the tissue inside. The stem cells inside, I'm sorry. And then so this becomes almost kind of a biological living tissue. And then you can implant this back into the person's body, and then using your own stem cell. And so that may be an option there. So there are clinical trials looking at these techniques as well. Right now, it's obviously more in the animal stages, so implanting these in the animal. So if you're an animal, these things work pretty well, but obviously you got to translate that to humans. So you have to make sure that these things will work. So this will be coming down the pipeline. So that kind of gives you an overview of what can be done from our perspective. But kind of going back to this slide here again, most of the people with low back pain don't need to have surgery. That's what I tell people, right? So most people don't need to have surgery, but you look for other ways to manage the situation. It's a main cause of disability. If we can reduce that, manage symptoms through, well, the genetics is hard to change, right? So, but the modifiable factors, such as diet, exercise, tobacco, keeping your blood sugar, blood glucose, control your inflammation through different means, and then the psychosocial aspect, how we react and cope with pain symptoms, how we coach ourselves to locate the pain symptoms and to have a positive response to that. I think that will be key to basically making this less of a problem for us, right? And then the people that it's up to us, the clinicians and doctors, to figure out who are the ones that have significant structural problems that will need ultimately will need some sort of intervention, surgery or non-surgery, and then go from there. So hopefully I kind of give everybody an overview. And then I try to inject some of the more contemporary treatment options that are out there, something that's new. I think is more in the news. And then so hopefully you have a little bit of understanding on that. And then at this time, I guess I'll take questions.
All righty, yeah, looks like we've got about 7 questions in our Q&A box and still open if you want to ask some questions while we're getting into the Q&A portion where Dr. Chen answers them. The first question we have is, what is lateral canal stenosis versus central stenosis?
Mm-hmm. So we go back to this slide here, yeah? So this part, this canal here that the horse's tail, the caudate canal is going through, that's our central canal, yeah? So that's in the middle. So people can have stenosis in this canal here, and then versus this hole here, we call the foramina or foramen. So that's where each of the nerves that comes out at different levels here. So people can have stenosis in these areas as well. So that's the lateral. So lateral stenosis, central canal stenosis. Does that make sense?
Mhm. And then what exercises are considered therapeutic?
So again, go back to the slides of the exercises. I think the consensus is still difficult. So depends on the type of condition. So the stenosis patients tend to, because the nerve fibers are getting pinched when people are extending. So extension tends to cause the stenosis to worsen. So the exercise the physical therapy do are more flexion based, meaning more leaning forward. So like recumbent bikes, and there's some kind of more of a flexion based stretches that tends to work better for stenosis. And vice versa. So soft tissue techniques, we talked about the massage and yoga, but again, those the level of evidence on that is, as you see on this, is relatively low. But I think it doesn't hurt, right? So our physical therapist usually will supplement it with that.
I have had an X-ray that shows degenerative disc disease. I'm not having pain. Do I need this treated?
So yeah, so that comes down to, so that's why there's some genetic factors, and I think there's biomechanical factors. So we talked about all these chemicals that we didn't go into all the specifics of these chemicals. And so just because there's an appearance of degenerative disc, people may not have symptoms because you don't have as much inflammation, you don't release as much of those irritable chemicals, and maybe the compression is not, the nerve is not as bad. Some people compensate it better than others, and then maybe the way you perceive pain is different, right? So if you're not as having as much symptoms, then maybe it's not as ominous. But there's always a but, because I tell people, pain is kind of like an alarm system for our bodies, right? So the pain is your body's way of telling you, hey, something's wrong, something's going on there. But in advanced stages of nerve injury, so when the nerve is so injured, then you don't sense pain anymore. In certain conditions, you don't sense the pain, but there is nerve damage there. And so that's why it would be crucial to have somebody have an exam and look over your scans and everything, because I have patients that come in and they have we call foot drop. So basically, you can't move your ankle because the nerve that controls the muscles, that doesn't work anymore, and they have severe stenosis, severe damage. But the patient tells me, well, I'm not in pain, so things probably not that bad. But in reality, the nerve is severely injured, so the prognosis is not very good because that nerve damage is done. So it's kind of a complicated answer. So, but for the most part, if you have degenerative disc, you're not having symptoms, probably okay. But if you're having issues like weakness, and if you can't keep your balance, you're falling, then probably it needs to look into it more closely.
How do you treat stenosis?
So yeah, so the stenosis is kind of what we talked about, the different approaches, right? So the stenosis in early stages, all you need is a decompression, right? So if your target is a specific nerve, that's the stenosis is compromising this hole or the central canal here, then you go in and basically shave out some of these bones or ligaments or their we call the ligamentum flavum, the yellow ligament, and you can shave out some of the arthritis around there and make more room, and give it more room. Then that may be all you need. Some of the stenosis may be too severe, so in order to get the pressure off of the nerve, you need to remove the whole vertebrae or the arch of the vertebrae or lamina, or if you had to remove significant amount of joint, then you need to figure out a way to stabilize it. Otherwise, the vertebrae, they're not connected together anymore, and they're loosey-goosey, and then they can injure the nerve. And so really the treatment, so that will be a tailored approach. So it depends on how bad, severe the stenosis is, and what the stenosis is causing the symptoms, what kind of symptoms you're having, and then we'll have to kind of determine, what type of surgery that you would need. Unfortunately, stenosis, they don't respond to the medications as much. Yeah, so anti-inflammatories or steroids, injections, they kind of help you with reducing the inflammation, but it's a mechanical problem. Something is mechanically pinching the nerve, so typically you need some type of intervention.
And what is the difference between minimally invasive and regular spine surgery?
So that's also kind of a complicated question. But in general, people typically think of mid-invasive, small incision, and mid-invasive. But the mid-invasive really, it's a philosophy where you're going into the spine without damaging all the tissues that are still healthy, right? So we call collateral damage. So if you go in to the spine and then you have to cut through a whole chunk of muscle here, or you have to strip out all the muscles, which is giving you stability, holding things together, even if you have a small incision, it's still, in my mind, it's still very invasive. So key thing is when you're approaching the spine, let's say the problem is right here, and you just target your treatment to this area and not disturbing the tissues up above or down below or on this side. We preserve all those tissues and just target to that, then you preserve all the other tissues, then that's less invasive. Yeah. And so that's why when you're doing a scope procedure like this, you're not making a big incision, stripping out all the muscles and going through the ligaments and everything. You're just going to that small hole and then right to the where the problem is. And so, but that requires precision, right? So usually we will do some sort of image guidance. So usually like a X-ray like this during the surgery. There are other things we can use like navigation. That's where some of the procedures like the robot comes in. So it's give you that precision like a GPS, so that you don't have to see everything and you know where things are, where your anatomy is. Hopefully that answers the question.
Mm-hmm. All right. The outside of my thigh keeps going numb. What might be the issue? Do I need to see a spine doc?
Not necessarily. So there are a lot of conditions that can cause that symptom, right? So again, going from if it's related to your muscles and ligament, you have these nerves here, again, the nerve fibers here. So in the thigh, it's very common that we see there's a condition called neuralgia peristatica. So it's usually, it has to do with the muscles, and then they have they're irritating these nerves, and those usually can be treated with exercises, and sometimes people get injections, but mostly exercises that can stretch things out. But it could be related to a nerve, a pinched nerve as well. So you probably need to at least have at least a primary care take a look at it, and then to determine whether you need more testing, either imaging or something we call EMG or nerve conduction to kind of figure things out.
How common is adjacent segment syndrome with a multi-level fusion?
Yeah, so that's why one of the things with spinal fusions is, like I said, basically you eliminate the motion here, right? So where the screws and the rods are. And what happens is you put stress on the disc above and below. So the joints above it will be this one here, the disc above it, and then the sacroiliac joint and the SI joint down below, they can start to wear out. And we see that on a frequent basis. But if you read the literature, probably about 25 to 30% of people that have a spinal fusion eventually kind of wear out the adjacent level. And unfortunately, that's kind of the stigma when people talk about fusion, because people say, well, you have a fusion, there's a good chance you'll be back for another one and another one. Unfortunately, that's just the nature of the surgery. Causes, the biomechanical forces to basically be shifted elsewhere, and then it's going to wear out the other joints. And so that's why sometimes you want to try to put off that fusion as long as possible, because the clock starts ticking once you fuse the vertebrae together, right? So.
Okay. If a female patient in her early 30s presents with increasing lower back pain and SI joint pain due to mild scoliosis left untreated due to minimal severity, would you recommend non-surgical approach with physical therapy, acupuncture, and anti-inflammatory meds, or a more invasive option?
No, you always start with the less invasive. So all three of the above is probably good. Yeah. I think, there's a lot of exercises. So the physical therapist, you kind of have to let them know, or chiropractors, you let them know that you're treating the SI joint, right? So there are different stabilization protocols, and that's more related to the sacropelvic. So there are exercises specific for the SI joint versus the lower back. And so you want to make sure that you do this right modalities in terms of therapy and exercises. In severe cases, certainly people get injections and things. And again, like I said, there's a surgery for SI joint. You can fuse the SI joint as well, but by far that's kind of the end of the road, right? So if you tried everything else, and then certainly surgery will be your last resort.
All right. Does an ablation procedure to the nerves provide long-term relief?
Depends on what you mean by long term. So when you ablation, so you're basically burning the nerve, or people call it burning the nerve, right? So you're basically using either heat, so you heat up an area, and then where the nerve basically kind of shrivels back. The problem is that those pain fibers, those nerve fibers, they'll grow back. And typically, so these type of things, they typically will grow back in about 2 to 3 months. So the ablation, usually you're looking for maybe a month or 2 or 3 effectiveness. That's usually kind of the ballpark. Some people get a lot longer term relief, but the nerve will grow back. And so what people do is they'll come in and get an ablation once in a while, maybe twice, 3 times a year, and that might be enough to manage their symptoms. And then ultimately, then the usual ablation, they'll lose its effectiveness, and the nerve keeps growing back, and they don't work as well anymore. But that gives you some time, and then once it loses effectiveness, then you start looking for other options like surgery.
And then, do you do robot assisted surgery?
Sure do. Yeah, we're one of the first group that offer the robot assisted surgery here in town. Right now, we're not using a lot of that right now. We're using something more in terms of navigation. The robot technology is still growing, so they can do more and more now. So the first generation robots are kind of not as sophisticated as you think it would, but the newer generations are getting better. So.
I've had 2 L5 area decompression procedures. Is a third possible, or more likely a fusion necessary?
Not necessarily. Yeah. So that's why you kind of want to put everything together. So, with the scans, and, correlate that with your symptoms, so you need to find out what you're trying to treat, right? And then where the symptom is coming from. So yeah, if you're in that situation, you probably need to see a surgeon and have a talk, and then kind of see what all the options are.
And then, do patients often need to have a second fusion surgery?
Unfortunately, it significantly increase your likelihood. If you have one fusion, like like I said, that the 25 to 30%, is going to need something down the road. And unfortunately, some of the could be genetics, like we talked about. Some people are just prone to wearing out their spine, right? And same thing like inflammation. And also, if you don't adjust your lifestyle after your fusion surgery, then you're just going to keep wearing things out, right? So we always tell people to, try to stop smoking if you can, try to lose weight, and have a good exercise and diet. So those are important too, right? So if you don't take care of your body, then it's going to wear out.
Alrighty. Are there any more questions? Oh, it looks like we have one last one.
Cool.
If there's no change in the patient after an injection, does it make sense to have a second injection to cover a larger area?
Yeah, that's a hard problem, right? So the way I look at injection, so the two goals you're trying to achieve. So one is diagnosis, and the other one's therapeutic. So we talk about diagnostic injections versus therapeutic injections. So if we already know where the pain is coming from, where the pathology is, then people go get a shot in the area where the pain is coming from. To relieve the pain, right? And sometimes we would do that for diagnosis because we don't know where the pain is coming from, because the MRI is so sensitive now. It pick up abnormalities, but doesn't mean that that's where the pathology is. So sometimes we had to go through send people for diagnostic injection. They had to go through different injections. Let's say if I numb you up one place and then you don't feel any difference, then that's probably not where the pain is. And then so you do another injection elsewhere, and then to kind of figure out if the pain is coming from there. So yeah, so sometimes people may need multiple injections, but if you say, hey, I have the same injection in the same place multiple times, they don't work, then it kind of hard to justify, say, hey, let's do more, right? If it doesn't work in that same area. But if it doesn't work here, it doesn't mean that it may not work injecting elsewhere, because if you don't know where the pain is coming from.
Okay. And then does diet and nutrition influence the healing after surgery?
For sure, yeah. That's why I kind of touch on that a little bit. I think that's something that kind of as spine surgeons we overlook that, right? So we usually kind of operate on the spine, make the spine look good, and then say, okay, see you later, right? So, but you have to treat the whole person, right? So once you have a brand new back, if quote unquote, then you still have to take care of it. So good exercise program, and we usually tell people, again, the biggest thing we see is weight, right? So try to lose weight now that if your back is feeling better. You want to have a good exercise program. Try to quit smoking if you can. Nicotine is a known risk factor for spine problems. And some of the things, subtle thing, get your sugar under control, diabetes under control. And we talked about this inflammation thing, right? So right now, like I said, the hot topic, people talking about gluten diets and how that causes inflammation. I don't know. We don't know who is more susceptible, prone to that kind of inflammation, and how that affects our spine. But we know that it's a negative effect on certain people. There are blood work markers that you can do to see people that are prone to inflammation. They tend to have a poor outcome.
All right. Well, thank you so much for participating in tonight's webinar, and thank you for all those who left questions. Our next webinar will be on May 5th at 7 p.m. Dr. Ralph Napolitano, a podiatrist and wound care specialist, will be speaking on how to get your feet and toes ready and looking great for summer. Look on our social media pages for additional information, and thank you and good night.
Thank you, guys.